Good evening, everyone, and welcome to another great session on precision oncology. And we are delighted and honored to have a very elite panelist and the chairpersons for this day's program. And I would like to primarily introduce the panelists and the chairpersons for the day's program. With us, there is Dr. Shona Nag, consultant medical oncologist from Sahyadri Hospitals, Pune, who is going to be the chairperson for today's event. We also have Dr. Mastura. She is the consultant clinical oncologist, Subhangajaya Medical Center and Pantai Medical Center, Kuala Lumpur. Dr. Annieyn Ong-Cornel, who is also the moderator for today's session. She is the director for Cancer Center, University of Perpetual Health Hospital, Philippines. Dr. Ferdous Shahriar would be joining us shortly. He is a senior consultant and coordinator medical oncology in Evercare Hospital in Dhaka. Dr. Shruti Behal, she is the medical oncologist at Max Nanavati Hospital in Mumbai. Dr. Ghanashyam Biswas is a consultant medical oncologist with Sparsh Hospital in Bhubaneswar. And there is Professor R.P. Bharat, who is the senior consultant medical oncologist at Norwich Hospitals in Kathmandu, and also the past president for SARC Association of Oncologists in the SARC countries. And also we have Dr. Vidya Veldor, who is the clinical director with us at 4-Base Care. Dr. Bharat Vaswani, consultant medical oncologist with Yashoda Hospitals in Hyderabad, is going to join us in a little while. Now with this, I would like to pass on the platform to Dr. Vidya Veldor to launch the session. Dr. Vidya? Dr. Vidya, are you there? Yeah, please. Not audible. Yeah.
Good evening, everyone. Good evening, everyone. And we welcome you all to this evening session. I hope there is no echoing of voice. I hope there is no echoing of voice.
Perfectly all right, doctor.
Fine. Okay.
Doctor, please move on. You can continue. Dr. Vidya, please continue.
Okay, yes. So first of all, I would like to thank all of you for taking your valuable time. Yes. So for taking your valuable time being here to discuss some of the important challenging cases in breast cancer. Yes. And I would pass on the stage to Dr. Shona Nag, who is the chairperson for today's session, and then to Dr. Annieyn following this, who is going to be the moderator. Thank you so much, madam, both of you, for this wonderful session.
So I hope everybody can see the slides. And
yes,
good evening to all of you, and welcome to this very, very interesting session on precision medicine in the setting of metastatic breast cancer. And it gives me great pleasure to introduce the topic. We see a lot more of locally advanced and metastatic breast cancer in India and in parts of South Asia and Southeast Asia as compared to the West. Almost 30% of our women present with large node-positive tumors, and another 15% have de novo metastatic disease. Data from the US SEER database shows that only 6% are metastatic at presentation. Even so, with improved treatments, the median survival of metastatic breast cancer has increased to almost 3.5 years. The gain is seen most in the HER2 positive group due to the availability of great antibodies and now antibody drug conjugates. The second largest gain is in the ER positive group. Triple negative, when metastatic, continues to carry a poor prognosis, and the median survival is less than 2 years. So this is a very nice article, a meta-analysis that was done by George Sledge and his colleagues, where they looked at the impact of different treatments in the metastatic or early setting in breast cancer. And this traces the trials right from the 1970s to the more recent trials in 2020. The solid lines are representative of overall survival benefit, and the lines which are dotted are suggestive of benefits in progression-free survival. And you can see that over the years, initially it was chemotherapy like CMF and drugs like tamoxifen and AIs. And later on, it was pertuzumab, TDM1, trastuzumab, and of course the CDK4/6 inhibitors, which have made a large impact. So the first example and the most important example to my mind till date of precision medicine in metastatic breast cancer remains tamoxifen. And this is one of the earliest studies done showing response rates of 49% in ER positive patients. It was approved way back in 1978 for the treatment of ER positive metastatic breast cancer and continues to save many, many lives all over the world. Finally, the more recent SCAT targets in metastatic breast cancer, and this is beautifully given in the SCAT guidelines by ESMO, which tell us that there are 4 important therapeutic biomarkers which have a 1A tier or level of evidence, and these are ERP2 amplification, now HER2 low disease, germline BRCA1 and 2, and PIK3CA. Of course, we need to also look at biomarkers for predicting response and resistance in metastatic breast cancer. We know that hormone receptor positive tumors keep evolving through each subsequent therapy, and it is very important to look for ESR1 and PIK3 mutations to determine the next treatment for the patient. So with this brief introduction, I will end my part and hand over to our moderator to take us through the rest of the topic. Thank you.
So, hello, good evening to everybody. After the talk by Professor Shona, we've come up with several real-world cases that we see in our country. And I'm sure it will also apply to some countries in Southeast Asia, which are also resource limited. So may I just share, we have 3 cases that we could give our opinion to. So may I just share my screen? Is this okay?
Yeah, absolutely.
Okay.
Yes.
So the first case is a locally recurrent triple negative breast cancer. What we have is a 62-year-old female, a non-hypertensive, non-diabetic, and she had breast augmentation and she had the Tabiso, wherein she received hormonal replacement therapy. Family history is significant for a mother who had breast cancer and an aunt who had endometrial cancer. So the illness was initially seen as an immobile tender left breast mass in the upper medial quadrant, around 6 centimeters. Consult was done and advised imaging, which was noted to have a subcutaneous soft tissue swelling, heterogeneous normal fibrous and glandular echo patterns of both breasts. Limited study shows multiple small hypoechoic cystic masses and no enlarged lymph nodes. A biopsy was done of the left breast mass. Histopath was invasive ductal carcinoma, but because of the COVID lockdown, the patient wasn't able to seek consult immediately. After several months, she was admitted in a hospital, underwent MRM with ALND, and the biopsy was invasive breast carcinoma, grade 3, largest tumor dimension 9 centimeters, positive for LVI, tumor less than 10 millimeters from the nearest basal lines of resection. All 13 lymph nodes and nipple were negative for tumor, background of silicon mastitis, and it was a PT3N0M0. The patient was triple negative for ERPR and HER2/neu. And so the questions right now for the panel, please feel free to raise your hand or answer our questions. So may I get the opinion of the panel members with regards to the role of neoadjuvant systemic therapy? May I ask who would want to answer first or give an opinion? Do I call out the names? Shall we start with ladies first? Mastura?
In our setting right now, if a patient presents with a tumor that is more than 2 centimeters and of a triple negative subtype, our preference is usually after discussion at the MDT is to offer the patient neoadjuvant treatment. So the patient will be given the option of either having neoadjuvant chemotherapy or neoadjuvant systemic therapy. That is a combination chemotherapy and immunotherapy. And the patient, if let's say the patient fulfills the criteria of what we consider as a high risk for, sorry, not high risk, but we follow the Manchester criteria for BRCA mutation testing. So the same patient will be given counseling for the hereditary germline panel testing. And meanwhile, the neoadjuvant chemotherapy or neoadjuvant systemic therapy will be proceeded while waiting for the BRCA testing result. So some of the doctors may actually, if let's say the BRCA testing results comes back as positive, then some may actually discuss with the patient about adding platinum to the chemotherapy, but some do not. So that's basically how we do it. Other than that, we also performs biomarker placement of the tumor, because usually we would prefer to do a breast conserving surgery for the patient after the neoadjuvant treatment. So the biomarker placement will be placed at either cycle 1 or cycle 2, so that the patient can have a better, a better surgery or breast conserving surgery will be carried out for the patient. So that's basically usually how we manage these patients. The adjuvant will be depending on what is the response to the neoadjuvant therapy, of course, but that can be discussed after this.
Okay, Shruti, any additional comments with regards to
I would just agree with the same. Yes.
Uh-huh.
So we prefer as NSCT as an approach for triple negative breast cancer for our patients, supporting the CREATE-X trial that later on, if we have residual disease, we can offer capecitabine. So largely our MDT discussions, we would prefer HER2 and TNBC patients, receiving upfront chemotherapy followed by surgery.
Okay. Dr. Biswas, any comments?
Because I think so. We missed out on the grade of the KS67, and all tumors today, as Dr. Smriti rightly said, so all T2 tumors will have a neoadjuvant, and all triple negative and grade 3 tumors HER2 negative. So we'll also subject the patient to a germline BRCA, so that will decide us on the later part, like the Olympia, if it is positive in a residual disease, or while surgery, so we can consider for a prophylactic mastectomy on the opposite side. So otherwise, it's a neoadjuvant for all into T2 disease or in plus disease.
Professor Beryl, any additional comments?
Actually, I agree with all the panelists. Just to remind, many years back when the concept of neoadjuvant chemotherapy came in oncology, the first disease was breast. If I do remember, the breast was the first disease to practice neoadjuvant chemotherapy. Now, in many cases, we are practicing neoadjuvant chemotherapy, but in breast, the miracle chances are there, as really mentioned by Dr. Ghanashyam. Even in early lesions also, and looking after all other parameters. In this particular case, I also prefer neoadjuvant chemotherapy, anthracycline or taxane-based chemotherapy, and go for surgery after the response. And after surgery, the treatment depends upon the entire pathological report, no doubt.
Okay. Okay, so it seems like everybody agrees with neoadjuvant chemotherapy. So I'd like to throw a question. Do you guys think that pembrolizumab have a role in this setting, or specifically in this case? And would we perform PD-L1 testing on the tumor? Anybody?
Yeah, Dr. Biswas, yes. So yeah, so we can do a PD-L1. So there are companion diagnostic for atezolizumab and pembrolizumab. For atezolizumab, it has to be a positive PD-L1, and for pembro, it has to be to see the benefit, that was a CPS more than 10. So that was the neoadjuvant keynote 522. So and the IM power 031. So where we'll be considering taxanes and pembrolizumab, and all these patients were exposed to anthracyclines, and later part post surgery, and they were continued for 9 cycles of pembrolizumab. So now the whole triple negative. So after the createx, the residual disease with capecitabine, now after Olympia in a BRCA positive with olaparib, and now pembrolizumab in adjuvant setting. So now there are many options. So we need to be choosing now. So there are problems of plenty in time to come. So that's why probably biomarkers will be becoming more important. Doing a CPS, doing a baseline BRCA is going to be an important stuff for treating triple negative.
Okay, Shruti, any additional comments?
No, I completely agree with Dr. Biswas. So yes.
Can I make a comment?
Sure.
Yeah.
Yes, ma'am.
I usually don't do PD-L1 testing in the neoadjuvant setting because it's really, if you look at the study, the keynote study, which is pembro is the only drug right now approved for the neoadjuvant setting, the benefit was seen irrespective of the PD-L1 status. So the real question is, if you do use pembro in the neoadjuvant setting, we really don't know what to do after that if the patient has a pathological complete response. So I think that's
I agree with
I saw you nodding.
I agree with Dr. Shona. Yeah, because I think we have to differentiate between using it in the neoadjuvant or in the metastatic setting. Because for the neoadjuvant is the keynote 522 with pembrolizumab, and there's also atezolizumab data for neoadjuvant. But so in the keynote 522, as Dr. Shona explained, the results were positive irrespective of the PD-L1 expression. So therefore, for this setting, we do not do it. And I think, Dr. Shona, for the discussion regarding adjuvant after the patient has had a PCR, right? If the patient has had a PCR, then there's this
dilemma,
this challenge, dilemma about whether the patient should continue with the adjuvant setting. But if the patient doesn't have PCR, then I would continue.
100%. Of course.
Yeah, and also for those who have node positive disease in the beginning or very large tumor that is like T4 tumors and they get a PCR, I will still discuss about this option. But if let's say they also have BRCA mutation, then I will discuss whether they would like to continue with olaparib in the adjuvant setting instead. So there's a lot of permutation, I guess.
I know. This is the thing with breast cancer. You have a lot of permutations and things to identify for treatment options. Professor Beryl, any additional comments?
Just to add, if I remember, this pembrolizumab came in 2020, and initially, even in our country, we never have practiced PD-L1. Now, because there was no strong lab, now after coming up this 4 base, we are starting baseline PD-L1 also, but agreed to Shona in first baseline setup, we don't are doing PD-L1. Just to remember this, FDA has approved pembro in high risk early stage TNBC with combination chemotherapy, and just to improve the progression-free survival. Now, I think the time has come. We should go for Pembro in neoadjuvant setup. Those patients who can afford. I don't know what is the cost in India. In Nepal, only at present, Beacon company provides pembrolizumab. Indian companies have not yet here. And Ghanashyam, 200 mg pembrolizumab in our country costs around 4 lakhs Nepali currency. So the question is how
2
many?
lakhs, 2 lakhs, 4 lakhs, 4 lakhs. तो हमारा देश में भी लगता है सर.
तो ऐसी होगा यार.
Same.
I mean to say this is very, cost effective. It's very, all patients definitely can't afford. So we should choose the patients. We should give the options. Some patients can't go for Pembro. Some patients will say, why didn't you give me the options of Pembro? So in initial setup, we should be very cautious to discuss with the patient party, but definitely it's a good drug, no doubt.
Okay. Okay, go ahead, because there's also a question in the chat box, but go ahead, Dr. Shona.
And I've also, ever since the brightness data came out and the meta-analysis came out, I have started earlier I didn't use platinum for every triple negative neoadjuvant, but now irrespective of the size or nodal status, especially if the patient is young and fit, I do prefer to use platinum in all my patients. I think it's a great way to improve event-free survival and get a good pathological CR.
The Keynote 522 actually uses carboplatin and paclitaxel,
It does.
right?
It does.
So
it
if
does.
let's say you plan to use pembrolizumab in your neoadjuvant treatment, then platinum is already there in that, in that study.
Yes.
So, yes, Shruti? Any additional comments, Shruti?
No.
Okay, no. Anyway, there was a question in the chat box, and this was answered by Dr. Yusof and Dr. Biswas with regards to metronomic immunotherapy. And as of now, there's no data. Okay, so next question with regards to this patient is, if the patient did either neoadjuvant chemo or neoadjuvant chemotherapy and pembrolizumab and did not attain pathological complete response, what will be our next adjuvant treatment strategy? Anybody from the floor?
I think for me, it depends on patient's affordability, of course. So if the patient has had pembrolizumab in the neoadjuvant setting but cannot afford in the adjuvant setting when they didn't have PCR, then I will discuss other options, provided this patient is BRCA wild type. So the other option that I will offer will be the capecitabine option via CreateX. If they can afford the pembrolizumab, then of course they go on the pembrolizumab adjuvant. And if they have BRCA mutation, then I will discuss giving them olaparib in the adjuvant setting as per Olympia. So it will depend on all these factors.
Shruti, any additional comments?
Yeah, I think so. In the adjuvant setting, we would like to take in the factors. If there is no PAT-CR, we would offer either capecitabine, as rightly said, according to CreateX, or Pembro, or according to Olympia, BRCA, PARP inhibitors to these patients. In adjuvant setting, if PAT-CR has not been attained. Yeah.
But when I ask the panel, how about if the patient wants everything? They are if let's say they are BRCA, they also had Pembro before, and then they say, okay, I want all. So how?
It is difficult to answer, Dr. Mastura, at this moment, because we don't have an answer to such questions. So things will be getting more complicated, and maybe in few years down the lane, then we can understand. So at this moment, things are cropping up and getting us more confused. So I think it is an exciting time for a triple negative breast cancer.
I know. Dr. Shona, any additional comments, Dr. Beryl?
So if the patient was clearly BRCA positive, and there is a good chance she might be, I think I would attack the driver and put on olaparib. There has been data for PARP and IO together, and that has been in other indications, but I'm not so happy with the toxicity. So if she was BRCA positive, my choice is clear. If, however, she didn't have a PAT-CR and was BRCA negative, if you look at the curves in Keynote 522, you see that in those groups that didn't achieve PATCR, the ones who continued or who had Pembro did far better than the ones who didn't get Pembro. So there is a benefit to continuing pembrolizumab in the adjuvant setting in those who didn't get a PATCR.
Dr. Beryl?
I agree, fully 100% agree with Shona, saying that if in first set of BRCA is positive, we go for olaparib, and there are a lot of holes to practice pembrolizumab, but as mentioned by Dr. Ghanashyam, not really any good trials, but they will come in near future.
So
I think because I think we also need to discuss the toxicity of adjuvant pembrolizumab, because we are treating, usually young patients, and, we do see patients developing a hypothyroidism and hyperthyroidism. They have, they have a high BP because of the hypothyroidism, and also to look out for interstitial lung disease when we're giving the patients this, long, like a year of treatment with such an, with the agent. So for the trainees out, who are listening.
So I guess the question on BRCA1 testing is already a yes in this patient. I won't even ask question. Anyway, I think Dr. Ferdous Shahriar, did I pronounce this properly, has joined us. Good evening and welcome.
He is muted.
You're muted, yeah. So just to update Professor Shahriar, we just finished the case on locally recurrent triple negative breast cancer, and we're moving on to the second case.
Okay, sorry, I got stuck with my last question.
That's okay,
Sorry.
that's okay.
Okay.
Not yet, because we still have something happening to the patient. So the patient had the tumor taken out, no adjuvant treatment received. It recurred, chest wall recurrence, an excision was done, and the excision showed high-grade carcinoma consistent with recurrence, lines of resection very near the lesion, lymphovascular invasion seen, and he was invasive breast carcinoma, mBC. And the plan was to do a metastatic workup. She was negative. She received systemic treatment and then RT and referred for genetic counseling and testing. So now that she was positive for BRCA1, what our thoughts on the adjuvant treatment plan for this patient at this juncture? I think it was partly discussed earlier, but any other comments? Professor Masood? Shruti, any other comments?
For this patient, setting, yes, because she's BRCA positive, right?
Turned out to be BRCA
positive. She's BRCA positive. Yes. Yes, we would consider giving her, PARP inhibitors, definitely in the adjuvant setting, for her. Because benefit, and we are targeting BRCA mutation. Definitely, yes. BRCA mutation is benefit of PARP inhibitors given to this patient.
But the Olympia trial actually was looking at the residual disease or a high risk patient. If this patient has undergone a surgery,
no, there was an adjuvant. There was an adjuvant arm as well, I think.
Yeah,
that was for a hormone positive, madam. So
no.
For
triple negative, any tumor more than 2 centimeters.
It's actually a HER2 negative tumor, means ER positive, HER2 negative, and triple negative. So they have adjuvant, and those patients who have high risk because they did not attain PCR from your adjuvant setting.
Yeah.
Yes, and
Shruti is lagging, I think. Sure, her connection is choppy. Anyway,
I think there's a very sorry, Annieyn. There's a very important question in the chat box asking about whether we should relook the hormone status again and HER2 status again after the neoadjuvant treatment, because this is also a very a common question that is asked by. So if anyone want to take that, I think maybe Annieyn can take that.
How about Professor Shahriar? Should we do a repeat
Post
the
neoadjuvant,
status
yeah.
again, then HER2 status again?
Yes.
The replay?
Can you hear me?
Yes.
Yeah.
Yes. Yeah, that's what I do regularly in my practice because, I have found and that recently, last week also, I found one. It has changed and it can change, 10 to 15% cases, this status changes. And then the whole scenario of management changes. So it should be done. That's what I feel after neoadjuvant and then surgery. If you have residual tumor, it should be done. Yes, regularly.
So I guess this only emphasizes the idea that we should repeat the hormone receptor status and HER2 new status with the
Yes.
Okay. We do not do that regularly or routinely in Malaysia for triple negative breast cancer, unless the patient, because usually they unless it's a heterogeneous tumor lah. So if let's say the patient do not respond to our initial neoadjuvant treatment, then perhaps we would repeat. But otherwise, I think that's not routine in our practice to repeat assessment in triple negative breast cancer.
Okay, so I guess we're done with the first case because we only have up to 8:30 to finish up this one. So for the next case, for the second case, let me just share the. So for the next case, we're looking at a locally advanced breast cancer. We have a 69-year-old female, left breast mass, 1 year, 2 months prior, palpable left breast mass, 2.5 by 2. At the lower outer quadrant, no axillary masses, no nipple discharge or retraction. Consultation was done and a breast ultrasound showed a ill-defined hypoechoic solid nodule with calcification in the 6 o'clock position, measuring 2 by 2.5 by 2 centimeters. So the impression during that time was a solid nodule of the left breast and suspicious BIRADS 4. Patient was advised consult with surgery service, again, lost to follow-up because of the pandemic. 4 months prior, they noted an enlargement of the left breast mass and sought consult. And this time, a CT scan was done and they found a left breast mass in the lower quadrant measuring 4.8 by 4.7 by 4.6 with poor planes with the underlying pectoralis and intercostal muscles. Lytic changes at the 5th anterior rib. Otherwise, the right breast is unremarkable. So the impression was a left breast mass with malignant features, and the one in the lung nodule was actually inflammatory lesion. So this is the scan. An upper abdomen CT scan showed a hepatic cyst. So in terms of metastasis to the liver, it was actually negative. Histopath showed an invasive ductal carcinoma, tumor size at 8.5, histologic grade 3, infiltration of the skin, no peritumoral lymphovascular space invasion, no perineural invasion, basal margin of resection is positive for the tumor, and there was 1 out of the 15 axillary lymph nodes present for the tumor. IHC showed an ER positive, PR positive, HER2 new negative left breast. So the patient had 4 cycles of doxo and cyclo and paclitaxel weekly for 12, adjuvant RT and adjuvant hormonal therapy. Unfortunately, after a year, the patient progressed with visceral lesions. Patient was started on CDK4/6 inhibitor plus fulvestrant. So questions. Number 1, does mBC have a role in this case? So any comments from the floor? Do you feel as of this point in time abemaciclib will play a role?
So as you told, so it is a CDK4/6. So abemaciclib is one of the CDK4/6, and this patient looks like a primary hormone resistant because the patient has progressed on 1 year of adjuvant hormonal therapy. So the strongest data is probably for a monarch. So we are looking at a monarch 2 here. So if supposedly the patient was an aromatase inhibitors, so definitely this patient becomes a candidate for one of the CDK4/6, and maybe your choice is abemaciclib because of a primary resistance with fulvestrant.
Any other comments? Professor Beryl, I see you nodding.
I totally agree with Ghanashyam because This is important CDK4/6, and in combination with letrozole or fulvestrant, we can try in second line, no problem.
This is the point at which I would like to rebiopsy.
Okay.
Because, I mean, we're all looking for a HER2 gain here, right? Hoping that will create another target. And if that's not the case, Abema is a great drug because we know it's used in more resistant tumors. It's a different CDK4/6. It's shown great survival benefit data, works well in visceral disease. So yeah, I think that's a reasonable choice.
Okay. Dr. Shahriar?
Yes, I agree with Madam. For visceral metastasis, abemaciclib is a very good choice in this case.
Of course.
Any more comments?
Usually, okay. Usually, patient like this, if they, presented with a very locally advanced disease, and if the patient has had adjuvant abemaciclib or did not have adjuvant abemaciclib, and if there are any disease that can be biopsied, we would, because nowadays we treat the patients with first line CDK4/6 inhibitor anyway. The choice of fulvestrant and abemaciclib here is what I agree, but I think the biopsy will give us more information about the disease pathology, because at current moment we heard about the Destiny-04 result, whereby the patients who have HER2 low may be able to benefit from trastuzumab deruxtecan, so that we can actually recheck the HER2 expression status. If it's 1+ or 2+, then we can confirm that, so that if the patient progresses on 1 or 2 lines of hormonal therapy in a metastatic setting, and this patient has had 1 chemo at least, then the patient can have that option of having trastuzumab deruxtecan.
Okay, so I guess doing a rebiopsy as of this point in time plays a role. Any other?
Because we can also do the PIK3CA, right? Because there are options for fulvestrant and alpelisib as well. So PIK3CA can also be tested.
The thing is, with hormone receptor positive, treatment options have gone a long way for the past decade, and makes it actually more challenging to come up with treatment options. That's why it's very important to get a repeat biopsy and look at the profile, and probably the molecular profile for treatment options. So, Doctor, anybody else?
I just want to know from Dr. Biswas, what is the cost of this abemaciclib there, and how we are practicing with single drug or in combination? Is there any dose modifications?
The single drug, actually, that is a monarch one for those who are heavily pretreated. So normally we are not using that. But yes, if you want to use a single drug heavily pretreated, so that is abemaciclib has the only choice, and not palbo or not ribo. So abemaciclib costs almost 90,000 rupees per month therapy. So after 9 months of purchase, rest lifetime is free.
Okay.
Okay. Dr. Bharat, have you listened to the case, or you weren't able to listen and be able to catch up? Dr. Bharat, you okay to get your opinion? Or we'll wait for you for the next case?
Yeah, can I give a comment, Dr. Annieyn? This is actually
go ahead.
Regarding access, because we in the the lower to middle income country, we have issues with cost, right? But I just want to know about clinical trials within our regions, whether these clinical trials are there, so that we can like better capture patients that are going to relapse. I mean, we have more locally advanced patients, such as this patient, very locally advanced disease at presentation, very rapid tumor progression, right? So if there are clinical trials for this population of patients at your regions?
In my region, I think yes, but the last I heard was for ribociclib and palbociclib with your fulvestrant and some targeted treatment. but during the COVID times, we had problems with opening up. I'm not sure with Dr. Shahriar or Dr. Nepal and Dr. Biswas in terms of the clinical trial, and Dr. Bharat.
Sir, yeah, I'm Dr. Bharat. First, sincere apologies for joining.
Oh, that's okay.
We have a trial where actually the problem with CDK, there is only one thing. What about a visceral crisis, which we all practice chemotherapy? So in India, we have few centers where the trial is going on, which we are trying to compare ribo with a chemotherapy in a patient who are supposed to have a visceral crisis as per as ABC5 definition. Something that we are trying. That is the only unexplored area, especially for CDK4/6 in a front line or in a later line in a hormone receptor positive or HER2 negative. What about a visceral crisis? Because in most of the study, that is one of the exclusion criteria. So we are having trial comparing that in India now going on in few centers.
Okay. Shruti, are you connected right now? Or
yes. I got connected. There was a network issue, so I kept my video off. So I think I should be on now. Yes.
So Professor Dr. Masood is asking if you have clinical trials also in Mumbai with this kind of medications.
Yes, we have clinical trials in Bombay, especially with having a lot of centers like Tata with us. So we do have clinical trials and run in Bombay. Specifically for breast, currently I'm not really aware of the ones running in our institute. We are planning to get in trials also of for the benefit of the patients. But yes.
Dr. Shahriar in Bangladesh.
Yes, unfortunately, we do not run any clinical trial of any sort at this moment in Bangladesh because of the regulatory body issues. And we'd like to start it for our own benefit, but unfortunately not yet. We have not yet started.
We have just finished sometime back. We just finished the Amelie trial. So Amelie trial was in a metastatic HR positive where ribocycline 600 was compared with 400 milligram. So that the trial results are yet to be out. So that was the Amelie trial. So the standard dose versus a low dose.
Dr. Beryl in Nepal.
No, any trials in Nepal. No. Not
Maybe Dr. Mastura, we should ask the other sponsors and the pharmaceutical companies to expand.
But we have, I usually do that because I always advocate for that and also early access program besides clinical trials in our part of the world, because we do have a lot of catchment because we have a high patient volume for these new innovative drugs. So I believe that access for clinical trials will increase our experience besides getting the access to all these drugs for our patients. And of course, once you are involved in this kind of activity, not just our clinical activity is improved, but also the pathology, the labs, the imaging and all that.
We have an adjuvant trial.
What about early access programs?
So we have an adjuvant trial for high risk HR positive where hormone versus oral ACRD is being tried. The oral
access programs. In my country, there are no access programs right now, presently, but before they used to have. How about in Bangladesh? Any access programs?
Yeah, we have a few access programs for few drugs from few companies. And in that way, we're getting benefit.
Oh, that's good. Nepal, Professor Beryl?
In other drugs, we have some access program, not in these types of drugs.
Dr. Biswas, yes, to access programs?
Absolutely. So we have access programs, access drugs,
access everything.
Access to everything.
Access everything, man. I guess Dr. Bharat will agree with you that you have access everything. It's a nice idea, access everything. So let's move on to the next question. So if the patient had progressed after the CDK4/6 inhibitor and fulvestrant, what will be our next step? And the corollary to that is, do we need to order comprehensive NGS or breast panel if this turned out to be a high-grade tumor? Anybody?
Okay, I'll take that. Okay,
Yeah,
usually, like I mentioned, this patient has risk. So what I will usually do when I start the patient on the first line CDK4/6 inhibitor plus fulvestrant or plus an AI, depending on the patient's preference at that time point, I will already ask for at least a minimum of PIK3CA mutation testing. If the patient has not had any BRCA testing, I will do that as well, because ER positive HER2 negative may benefit from olaparib or talazoparib in the metastatic setting. And if the patient can actually afford NGS testing, then I will do that, because there are some information that I can get other than what we already know in breast cancer. I can check for tumor mutational burden, and I can check for microsatellite instability, because if the patient has run out of options, I can use this in order for me to treat the patient with immunotherapy later. And of course, like I mentioned earlier, I will check for the HER2 expression so that to see whether this patient can actually go for the TDXD.
So I guess this is the situation we're in. Biomarkers will really play a role. Anybody else? Any other comments? Shruti?
I would like, yes, I would like to add just one biomarker else. If we add NGS, would be NTRK, which would help. Rest, I think so, has been well completed. The list has been really completed by doctor already. So NTRK, yes, that would be another one we would look into.
Your thoughts, Professor Shahriar, on the biomarkers they've suggested, or we're okay?
Yeah, we are working, and this thing is one thing that our colleague has mentioned beforehand. Whatever we do have to do re-biopsy and biomarker test study whenever there is a progression, and then accordingly we proceed. Dr.
Bharat, anything to help us out?
Agreed. No, I agree. Whatever Madam said, PIK3 is something that we need to do it. Apart from that, NTRK is something that we can pick up additionally through NGS. MSI high CPS, probably triple negative, more relevant, but yes, a high CPS, more than 20 in the later line, definitely immuno-oncology is one of the options, provided other options are exhausted. And one BRCA, which already told. So BRCA, PIK3, these are two, and NTRK, this we can pick up through NGS. And apart from that, yes, MSI, what Madam told, and MSI and CPS. That is what I think should complete a list.
Okay. Well, in reality, some of our countries have limited resources. So any suggestions on what is really essential in this case?
I think so. I'll answer. Madam, PIK3 is something that I think we should do it. Being a hormone receptor positive, 40% will have a PIK3 mutation. And now, if again, we can do a test, probably if we have the drug is available now, at least in our country. But again, the cost is again an issue here. Again, what Madam told is trastuzumab deruxtecan, again a drug not available in our country. So probably after, if alpelisib related is, otherwise we go towards the Bolero thing in our country now. Suppose chemo is always an option, but everolimus and with some of the AI, that is something that we do once they progress on a second line fulvestrant containing, provided we cannot, the PIK3 was negative, or we did not have the affordability for alpelisib. Third line, we prepare our everolimus plus exemestane. And then later on, yes, BRCA, depending upon BRCA status, otherwise chemotherapy is the last thing to follow.
Okay. Professor Beryl, any comments?
My just comment is, this is the era of molecular pathology. And the treatment is individualized depending upon molecular biology and genetic mutations. So we should have good options for this biomarker profiling, and all the treatments depends upon the biomarkers.
Biomarkers results. Dr. Biswas, any other before we move on to the last?
Since we are a part of the SPEAR trial of Novartis, so all our PIK3 is absolutely free. And we'll soon have the EPIC-4 trial, so where the patient will be getting in the alpelisib free also. So one arm is alpelisib and the other arm is alpelisib plus the anti-diabetics, because we know that so alpelisib is a drug which is glucogenic basically. So the patient gets high sugars, no? So all these patients will at least go for a PIK3 and the germline BRCA testing. So these are minimum tests that are required. If the patient cannot afford, so we have a clinical trial, we have a patient company support program, so that tests are done at least. And if somebody cannot afford, as Dr. Bharat rightly said, so they go for some sort of a bolero, because today bolero protocol, like with exemestane and the lower dose of everolimus.
So I guess this really emphasizes the benefits of the presence of clinical trials and access programs. Anything else before we move on to the last case? We're okay. So for the last case, what we have is metastatic triple negative breast cancer. Share. So we have a elderly female, 78-year-old female, postmenopausal, hypertensive, non-diabetic, no family history of cancer. She noted a left breast mass, tender fixed, 5.4 centimeters, no nipple discharge. The biopsy result was invasive ductal carcinoma. Metastatic workup was negative during this time. It was invasive ductal carcinoma grade 3, tumor size 5.5, no nodes, positive invasion of pectoralis muscle, and positive nipple invasion. So the IHC was triple negative. She received adjuvant systemic treatment, AC4, docetaxel 4, and adjuvant RT. But 1 year post-treatment, a surveillance with the PET-CT showed pulmonary metastasis. Luckily, the patient has good performance status and remains asymptomatic, so she was started on eribulin for 6 months. The surveillance imaging showed a decrease in the number of lesions in the lung, and she opted for a drug holiday for around 3 months. After the drug holiday again, the imaging showed an increase in the pulmonary lesions. Patient is still good performance status at ECOG 0 and asymptomatic. She was started on vinorelbine for around 6 months. Repeat imaging again, disease progression, still asymptomatic and ECOG 0. So our question is role for rebiopsy. Would a comprehensive NGS be done in this situation? And if ever we have challenges in obtaining a tissue, because this is a lung lesion, would a liquid biopsy suffice? So who can start the ball rolling?
So I think there's definitely a role of rebiopsy. So there is a 10% chance we might get a hormone positive. If it's still a hormone negative, you can do an androgen receptors, because this is now a 73, 74 years lady now. So we may not be able to push much of cytotoxic. So there can be an androgen receptors. So there can be a PDL1. So in a palliative setting. So I think so we should do a rebiopsy. So one will show that if it continues to be a triple negative, then additional androgen receptors and PDL1 is going to help. And if it turns out to be a low HER2 positive, then again, so if the patient can afford, then already, so that testosterone deruxtecan is already there. So I think so there is a place for it, because already 3 lines of therapy now. So the patient is not responding. If the patient GC is good enough, and since there are a lot of lung lesions, and today lung lesion biopsy are rather more easy than doing a biopsy from many other places.
Okay, Professor Beryl, I saw you nodding. Any additional comments?
My just one question is that maybe I'm right or wrong, I don't know. After 6 months of eribulin, there was given drug holiday in this case.
Yeah.
I don't know what is the borderline treatment. I mean,
she opted to rest from any medications. She requested that actually.
So we could have considered for an oral capecitabine.
Exactly.
That is a good drug for a
drug holiday.
Even gemcitabine is a good drug.
Exactly.
Yeah.
After drug holiday, she again progressed and vinorelbine was given.
Yeah.
So I think there was a lap, and according to Dr. Ghanashyam, biopsy, 100%. I agree. I should do. We should do biopsy as mentioned by Ghanashyam. It may change the hormonal status. We have many patients. The HER2 status or even has been changed after biopsy, and the treatment totally depends upon the biopsy.
That's true. Professor Shahriar?
Yes, I agree with Dr. Beryl. Yeah, rebiopsy is, we do it regularly, as I have mentioned before. and accordingly move forward. And, taking into consideration of the comorbidity, age factors, and all these things, whatever is a good option for this patient, avoiding just very troublesome side effects, we can go for that.
Yeah. Shruti?
Yes, definitely biopsy has to be done in this patient. And if because the metastatic site is lung, role of liquid biopsy, as there in the further questionnaire, there is a role. It will not only help us to get easy access of tissue, but also little heterogeneity of the tumors will also be well seen if it is a liquid biopsy. So liquid biopsy along with the tissue which is there in for most labs can be a good approach for this patient.
Dr. Bharat?
Heavily treated patient, probably we have exhausted our option of eribulin and then oral minorelbin, if I'm not getting wrong.
Yeah.
Probably liquid biopsy, madam, the options are limited. So probably some new mutation, liquid biopsy, I'm not sure, for at least re-biopsy you should at least do one time in a metastasis. If the patient comes from adjuvant, if there is a recurrence, definitely we need to do a biopsy. One is a BRCA mutation. Probably I'm not sure whether we have ruled out or not, whether the patient has a BRCA or not. And probably, yes, in the later lines, again, what we say CPS scoring, we should do it. You have a more than 20, probably some role in the later line immunotherapy. MSI high, again, a role of immunotherapy. Then again, probably not much, but there are some drugs targetable, although this is not AKT inhibitors are there. There are for PTEN loss, there are drugs, but probably not available in our country. But theoretically speaking, yes, you can pick up some new targetable mutations and probably one or two options may come up. But and I agree with what previous speakers have said that if HER2 is low, we have an option of trastuzumab deruxtecan, capecitabine, gemcitabine, apart from what I have said.
Okay. Dr. Yusof?
From my perspective, I think a biopsy of the lung lesion has to be done in the first onset of metastatic disease. So either get it done via CT guided biopsy, or if it's near to the to the airway, then probably a chest physician can help us in doing that. And the reason for the biopsy is because this is a patient that is a candidate for immunotherapy in the metastatic setting, whereby you have to check the PD-L1 status in the metastatic tumor. And you can't do that with liquid biopsy, because if you're looking for the CPS score, that is actually that is from tissue, because you have to basically calculate the PD-L1 expression out of the tumor and the immune cells, and then over the whole tumor existence in that tissue. So you are not able to actually do that from NGS in terms of answering whether this is PD-L1 positive or not to get the CPS score 10 or more. But if let's say the patient now comes up after the patient has already had first and second line treatment such as this, I would discuss with my patient about re-biopsy at this juncture. Because if the patient is 78 but yet able to actually endure eribulin and endure vinorelbine, then she must be fit enough for me to actually do that for her. And then from that biopsy, I think this time around, because she has failed those two therapies, then I would do the NGS. And nowadays, we in such a patient, if let's say they are keen to have treatment, then we will do the true site, the TRO 500, where we do both RNA and DNA genomic analysis, so that we can have more targets or biomarker that we can use to choose our therapy at this juncture. But of course, immunotherapy is still available for this patient should she fulfill the criteria.
Okay, so we have actually finished 3 cases, and we've looked at the different scenarios, permutations, different presentations. And I think what we've realized is that biomolecular markers or testing is really very important in terms of pointing us to the direction as to what treatment options are available and to the possible prognostication and behavior of our patients with breast cancer. So with that, we've done an hour of breast cancer management and case discussion and opinions from everybody. So before we end, Dr. Beryl, our chair, any last comments before we wrap up the whole thing?
My comment is not to panelist or chairperson or moderator. My comment goes to Forbes company. Really, we should give thanks to Rameshji and entire team for hosting this and inviting us. And for every test in every part of the world, either Philippines or Malaysia or Nepal, Bangladesh, they should compromise with cost, because one is social aspect, servicing to the patient, and secondly, to increase the patient volume, your cost should be targeted. And in near future, we hope that these types of sessions should be hosted in on regular basis. Once we have done this time, and next after 2 years has no sense.
So thank you very much to everybody. Vidya, any?
Yes, no, I would just like to thank all of you. And if you would like to summarize the discussions today, would you like to give some take-home messages from a collection from all of you? Would you want to give any comments on that?
Anybody would want to give their last comments?
Today's.
I'll try to give something.
Yes. Sir.
Now, molecular, the thing is, the advent of molecular diagnostics has come a long way, and more so in the later part, because probably breast is probably one of those organs where this started a bit late. We are too ahead in lung cancer. If you see, we do a lot of moleculars. But in breast also, I think the time has come more so in the metastatic setting, maybe also in early, that we should start doing our molecular testing for all of our patients, I can say, not only triple negative, because now over a period of time, two things is important. One, we have a targetable mutation that we know, and probably over a period of time, we'll probably know what is the genomic pattern in probably in de novo or in metastatic, and that could only be possible when we encourage our patients, or when we should discuss with our fellow colleagues or physicians, medical oncologists, to start doing it, because that is a need of the hour. Probably we'll have new targets coming up in the near future, new drugs. So we are in an exciting time, but the thing is, molecular things should be re-emphasized, and probably a more emphasis should be placed on all these things.
Okay, Vidya, I think that summed it up.
Yes, thank you so much, Dr. Bharat, for this comprehensive summary. There's only one thing, although I come from science.
Sorry, Vidya, can I add?
Yes.
Can I add something?
Yes,
I think we have to also promote multidisciplinary team discussion. Yes. So since we have learned from COVID-19, right? Before this, we used to assemble everyone, and everyone meets, and then look at the imaging, look at the pathology report and all that. But it's since COVID, we can actually do it via teleconference. So by doing the multidisciplinary team discussion, then we can discuss the patient management better, other than having biomarkers, other than having, so that sometimes we can inform our colleagues about neoadjuvant, about looking at survival data, about the improvement in advanced in adjuvant setting, as well as if there are any access or clinical trial available, or sometimes we can let them know about molecular testing, because sometimes maybe the surgeon do not know about PIK3CA and all that. So when they actually send the tumors for pathology, then they can actually ask for that if they are well informed, and we can do that through MDT.
Very, very well. Yes, agreed. Yeah, only one thing, role of anti-angiogenic inhibitors we did not touch upon. Is there anything that we want to add in the breast cancer?
I think because the data for that is actually not so strong, but in triple negative breast cancer in the second line setting, there is a recommendation that we can use, but it's not a must. So I guess in triple negative breast cancer, since we have data for sacituzumab govitecan, we have data for TDXT, maybe the role of Avastin is, or anti-angiogenic agent is going to be even lower and lower.
Okay. Thank you so much then.
Yeah, I add on what ma'am said. TNBC is probably one subset where we can, because of the other drugs are not available in our country. So we shouldn't think of anti-VEGF or anti-angiogenic in triple negative. Unfortunately, the first trial, which was weekly 30, was ECO 3200. Probably that was something which gave us a lot of hope. Unfortunately, that hope was not what sustained with later studies, but I agree with what Madam said. Is that TNBC definitely some role of anti-angiogenic, probably with a taxanes.
Okay. Vidya, anything
Yes.
more
No,
before
no,
we wrap
madam.
up
Thank
the
you.
discussion?
Thank you
Yeah,
so much. Yeah.
Thank you very much for being very courteous and pleasant in attending this roundtable discussion. We hope to hear from each and everyone again, and probably hopefully see each other again. Dr. Beryl was inviting everybody to Nepal and probably to Mumbai from Shruti. So Vidya, if there is no more points to discuss, then shall we call it a night?
Yes. Thank you all once again for giving your valuable time and sharing your experiences from different challenging cases in breast cancer management. It has been a really great educational session. Thank you all once again.
Thank you, everybody.
Thank you.
everyone.
Good night.
Bye-bye.
Thank you.
Bye-bye.
Good night, everyone.
Good night.
Bye-bye.